Welcome back to another episode of Oncology for the Inquisitive Mind, where I have fancy new equipment, but Josh doesn't need any fancy new equipment to be the best presenter around. I just came up with that. How about that? Josh, we are talking about pancreatic cancer, and it is a very depressing topic, but I hope that doesn't apply to how you're going today.
Yeah, no, I'm doing well. You're right. It is a somber discussion point, and one of those many cancers we talk about where I wish there were some leaps and bounds in like the world of breast cancer.
Yeah, I think incremental is the word that is used to describe progress in pancreatic cancer, but that doesn't mean there's no progress at all. We've got two studies for you today, and Josh is going to lead us off with the Napoli trial. That's one for all of you football fans out there.
Oh, good job, Michael. You know, that went right over my head.
Right over your head. I couldn't resist.
You couldn't resist just showing me up. Let's talk about Napoli 3. So the background, as Michael said, advanced pancreatic cancer is rough. 5-year overall survival is 3%. There are a couple of approved regimens already. There's FOLFIRINOX, the classic fluorouracil based, and there's abraxane, which is there's gemcitabine and nab-paclitaxel, essentially, or have also been approved. And then emerged as first-line cases throughout the world. In Australia, I think it has to be FOLFIRINOX, and then it's abraxane from memory when it comes to the pancreatic space.
Unless the PBS has changed, Josh, it's the other way around.
That's what...
Gemabraxane, the only reason we use gemabraxane first line is because we have to at this point.
Okay, well, there we go. It's been a couple of years, Michael.
That's fine.
Good to know. So, but we're talking about a new sort of regimen. I think the point of talking about FOLFIRINOX versus gemabraxane, there haven't been any true head-to-head studies. So, whilst, yes, potentially it's been approved as the first line, it's not actually shown to be, you know, the best combination out there, although potentially a more expensive option. So what we know is there's a drug called irinotecan. It's a topoisomerase 1 inhibitor. We harp on about that a lot because a lot of the antibody drug conjugates have topoisomerase 1 inhibitors on them. The mean active metabolite is something called SN38. And they've made a liposomal irinotecan version of this, meaning it remains in circulation for longer than the unencapsulated irinotecan before being converted to SN38. So theoretically it has better outcomes. There's a couple of prior trials. There's a Napoli 1, which showed that liposomal irinotecan and fluorouracil and leucovorin improved overall survival versus the standard of care arm, which excluded that drug in patients with metastatic ductal pancreatic cancer, I think after a couple of lines of therapy. There was an early phase 1-2 trial, which is comparing NALIRIFOX, that's what they're calling this combination, in treatment-naive patients. It was an early study, so I think it was a single arm. And it had a median progression-free survival of 9.2 months and an overall survival of 12.6 months. Pretty terrible. But obviously there's some data there that supports it, but not a great cohort. This study was a phase 3 looking at NALIRIFOX compared to gemcitabine and abraxane. It was randomized 1-to-1. Their primary endpoint was overall survival, and the secondary endpoint was give me a sec, I'm going to bring up my slides just so everyone else can see it if you're on our lovely social media YouTube thing that we're trying to do. And the secondary endpoints were that of progression-free survival and overall survival. So 770 patients randomized 1-to-1 to each of the arm. And this is where the data already starts to get a little bit sad. At the end of the trial design, this is the design cohort. Only 44 patients in the NALIRIFOX arm were still on therapy, and only 7 patients in the gemabraxane arm were still receiving treatment. That is about 12% and 2% respectively. The results are also somewhat sombering, apart from that somber fact, is that after follow-up of 16.1 months, the median overall survival was 11.1 months in NALIRIFOX and 9.1 months in the gemabraxane, with a hazard ratio of 0.83. The overall survival was 45 versus 39%. The overall survival at 18 months was 26.2% versus 19.3%. When you look at median progression-free survival, it was 7.4 versus 5.6 months, favoring NALIRIFOX with a hazard ratio of 0.69%. And at 18 months, PFS was 11.4% and 3.6% in the control arm. So not many people didn't progress after 18 months. So really difficult. And median duration of treatment was just under 6 months for the intervention arm. Adverse events are relatively comparable. So for once in my life, I can say that the new drug combination was not more toxic than the existing drug combination. So that's really something to say. And if you look at the sort of breakdown and sub-analysis, it also does favor NALIRIFOX, but ultimately, like many of these really difficult cancer types, it's difficult to prove. Yes, it's slightly better, but there are some issues, and these are things I'd like to sort of highlight, Michael. The first one, if you go on the Twitter sphere or even just go to analyses of this, it's like this sort of two divides. Some people are like, "Yep, it's the standard of care. Let's just go with this first line." Other people are like, "Well, hold on, 3 drugs are going to be better than 2." As a general consensus, unless the third drug has no activity at all. Should they have used FOLFIRINOX as the control arm? Because that would have been the interesting one, because it's sort of 2 formulations of irinotecan, right? So it's like, all right, is A going to be better than B? That is probably what should have happened. And so the question is this 2 months, and yes, I appreciate there are people who will jump at that. And like small cell lung cancer, we got a 3-month benefit when you look at it. All those sort of trials, is it actually worth it? And so what I'm saying by that is for the cost of liposomal irinotecan, does that, cost shouldn't come into effect when it comes to patients, but like, are we actually doing anything in a real world setting? And there's not a lot of real world data just yet, but I think it's something that you have to kind of ask, especially when at 18 months, very few patients were on this anyway. So you're not going to get huge numbers going to that point as well. So my summary of this is that it is an option. I think if they're young and they're robust, you can do it. That's not even toxicity related. It's just more so pragmatic that people in their, they're in their 40s, they might live longer than people in their 70s. Not saying that you shouldn't challenge it if they're going to trial it, but these are just sort of considerations. But I don't think it is a game changer when it comes to what we should use first line. Of course, Australia, as Michael so eloquently corrected me, is still abraxane. I did do this, but it's been about 5 years. So I'm going to give myself a small little pat on the back and break from not getting that right. But yeah, that's the summary, is that one is not actually that much better than the other, but incremental improvement. So you can have that discussion and say, hey, look, this might be better for you, but not necessarily going to be the game changer that we wanted.
Yeah, incremental, I think, is the appropriate word. And I think we'll all give you a break off the taunting for not knowing the PBS thing for a cancer that you don't commonly treat, Josh, because it's hard enough to keep up these days with the cancers that you do treat. So we know that liposomal irinotecan isn't the silver bullet that we wanted, but the study I'm going to discuss, which is called PANOVA-3, goes in a very different direction, Josh. And it is examining the use of tumor-treating fields in the treatment of locally advanced, not metastatic, that's the first thing to say, locally advanced but unresectable pancreatic cancer. Now, don't worry if you're listening or watching this, you haven't switched over to a different podcast. Tumor-treating fields do actually have evidence in certain tumor types. So they are currently FDA approved for the use in glioblastoma in combination with temozolomide, as well as mesothelioma in combination with chemotherapy. The idea behind them is that they use low-intensity electric fields that disrupt cellular processes critical for cancer cell viability and tumor progression. That's a direct quote from the study PANOVA-3. And so the thought was, well, pancreatic cancer continues to be a nut that we are really struggling to crack. We have, data about resectability that Josh very, very thoroughly went through in our last episode. And if you want to listen to that, please do go back and listen to it. And as we always say, subscribe, like, all that sort of good stuff. Josh is smiling at me because I'm doing my job. So can we use these tumor treating fields, which have benefit in some other difficult to treat, immune cold, not a whole lot of targetable mutations. Those tumor types, it seems to have some benefit. Can we use it for locally advanced pancreatic cancer? So PANOVA-3 was a global randomized open label phase 3 trial for patients with locally advanced PDAC. I like that they had to define that it was open label because, otherwise there'd just be people strapping bogey or dummy pads to themselves. Eligibility criteria: patients had to have unresectable, locally advanced, biopsy confirmed, and previously untreated PDAC. So this is a first-line study. They had to have expected life expectancy. Expected life expectancy? Yep, that is something that I've written.
Is that like more than 3 months, Michael? I'm assuming
more than 3 months, exactly. But I only realized how much of a tautology that was when I said it out loud. That's podcasting for you. They had to have an ECOG performance status of 0 to 2, and rather understandably, they also couldn't have any implantable electronic medical devices such as pacemakers, because if you're going to be zapping someone, you don't want them to be reliant on an artificial pacing. Or that they couldn't have severe hypersensitivity to medical adhesives or hydrogel, which again is very understandable. Patients were randomly assigned 1-to-1 to receive TTFields with gem-nab-paclitaxel or gem-nab-paclitaxel gem-abraxane alone. Interestingly, and we'll talk about some of the practicalities in a moment, but the TTFields were delivered at a strength or frequency. Josh, I didn't do physics, so I don't quite understand the difference between strength and frequency, but 150 kilohertz is the number of something that you're looking for in this study. And they had to have a recommended usage of greater than 75%. So that's greater than 18 hours of the day every day, so 3/4 of the day. The endpoint, the primary endpoint, was overall survival. Secondary endpoints include, and I'm going to go through all of these because normally we sort of, rush through secondary endpoints, but there are some that are quite interesting here. So progression-free survival as well as local PFS, 1 year overall survival. The interesting ones, though, are pain-free survival, which they've defined as the time from randomization until a greater than or equal to 20-point increase from baseline in patient-reported pain scale. And they've used a visual analog scale for that. Puncture-free survival, which is a rather aggressive way of saying the time to from random assignment until first need for paracentesis, so acidic drain, effectively. Resectability rate, so are we, with the use of TTFields, effectively converting unresectable pancreatic cancers to resectable? Spoiler alert, unfortunately we're not. Overall response rate and safety. So as we can see from the consort graph here, they randomized 571 patients. And the demographic notes, as we always sort of go through, there were high rates of female patients in the chemo-only arm, 56 compared to 43%. 43% of both arms were located in North America. 58% of patients had an ECOG performance status of 1. And 30% of patients had a CA19-9 of greater than 1,000 units per milliliter. The median duration of chemotherapy at the time of data cutoff was 24 versus 23 months, which with the gem-abraxane schedule equates to about 6 cycles, with a cycle being 4 weeks. And the median duration of TTF exposures was 27.5 weeks. Interestingly, you might remember that the recommendation was exposure for 75% of the day. The median device usage actually fell below that threshold. It was 62%. Interestingly as well, the range that was stated in the study was 0% to 99%. So you had the full spectrum of people who were randomized to receive TTF. Some just didn't use it or didn't wear it. Maybe they didn't turn it on or something. Whereas others used it for 100% of the day, which shows you the variability. Now we come to the overall survival. And Josh used the word incremental a couple of times, and incremental is what we've got here. So it was statistically significant, but we're talking a couple of months, 16.2 compared to 14.2 months. The 1 year overall survival was numerically higher, 68 compared to 60 months, but again, incremental changes. There was no significant difference in progression-free survival, 10.6 compared to 9.3 months. That was not statistically significant. The 1 year PFS, though, was statistically significant, 43.9 compared to 34%. So I'm not really sure how to explain that really, but you're still not getting an average progression-free survival of more than a year. I think that's the important thing to say. The pain-free survival was better, and this is an area that I did want to highlight. It's 15 months compared to 9 months, which is, I think, from a quality of life perspective, huge, because anyone who's treated pancreatic cancer will have had patients who have the primary effectively encroaching on the celiac plexus. And that can cause incredible, agonizing pain. And it's pain that can be very resistant to opioid analgesia and adjuvant therapies like pregabalin, as an example. And it's often very difficult to irradiate. I've had patients who have had to go for celiac nerve blocks, and those have a high rate of failure. So delaying the onset of pain from locally advanced pancreatic cancer is quite significant. The overall response rate was not statistically significantly better with the TTFs versus chemotherapy alone. So we're getting really mixed results here, Josh. And as I said before, there was no significant difference in resectability rates. So we're not converting patients from unresectable to resectable or even borderline resectable. And there was no difference in puncture-free survival as well, which was a bit disappointing. In terms of safety, we know the side effects for gemabraxane, so I'm going to skip over those. But the device-related adverse events with were largely mild to moderate skin reactions, which accounted for about 3/4 of patients. And these included dermatitis, rash, pruritus, maculopapular rash, and erythema. And anyone who's been involved on a trial and has tried to classify things using the CTCAE guidelines will probably guess that those are frequently 4 ways of saying roughly the same thing. In terms of tolerability, though, about 8% of patients experienced a grade 3 or higher device-related adverse event. 8.4% had device-related adverse events that led to a discontinuation. And this was the difference between discontinuation rates in both arms, because the rates for discontinuation from chemotherapy were broadly similar. And it's important to note that there were no grade 5 device-related events, probably because they selected patients without predisposing factors like pacemakers. So where do we go with this? So PANOVA 3, it is an interesting, and Josh is shrugging, and I do agree. It's an interesting application. The improvements in pain-related survival are particularly interesting, as I said, for the quality of life improvement. But I just wanted to finish by showing a picture, and I got this from the website of the Brain Tumor Charity. And this is for a patient, a gentleman who's given his permission for his picture to be used online. But he's, as you can see, he's got tumor treating fields, presumably for glioblastoma, because the pads are over his head. Now, I want to draw your attention to the backpack because this is actually how, and the reason I've used this picture is it's really the only picture I could find. But this is how these tumor treating fields, this device is actually transported. So people do have to lug around a backpack for 3/4 of the day. Which might indicate why you had that huge range in compliance and why the median range fell below the recommended threshold of 75%. The other thing as well with this technology, as far as I'm aware, it's not available in Australia. And much like your conclusion with NALIRIFOX, Josh, it's going to be
3, Michael.
Napoli 3. Napoli 3. I'm really starting to lose it. But much like a conclusion with that, it will be down to a discussion with the patient, because some people will see this 2-month overall survival benefit and, a delay of the onset of worsening pain and say, yeah, I'll carry around the device for that. Others will say it's not worth it, much like with the liposomal irinotecan. So I guess the only question I have is, as you mentioned right at the start, Josh, we have gemabraxane, which in Australia we have to use the first line. Numerically, FOLFIRINOX is better. I think it's something like 8 versus 12 months in the separate studies. There's no head-to-head trial, as you said. So could tumor treating fields be combined with FOLFIRINOX? I think you're going to run into toxicity issues with that. But it's a theoretical option. And, once the technology improves, maybe to like a diabetes insulin pump that you carry around on your hip these days. I know those used to be backpack form as well. So once the technology improves, it might be a bit more palatable. It'll probably be cheaper and more widely available as well. So that is where we are with pancreatic cancer, Josh. A very, very quick run through, but like we said, there wasn't a whole lot of groundbreaking new studies.
Yeah, it's a bit of I think a reminder of just how difficult some of these cancers are still to treat, and just really makes it, it hits home, because, you treat these guys knowing that there's a few that will do really well, but a lot of them will just really struggle.
Absolutely. So next week, where, as Smash Mouth once said, the hits keep coming and they don't stop coming, because we're going to be talking about biliary tract cancer. Another very, very difficult tumour stream to treat, but one that has seen a little bit more success in the development of new regimens. So we hope to see you then. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more, at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.